So today's our focus would be another clinical scenario. This again is integrated with the clinical anatomy of the upper limb. And let's move on to the question. So a 26-year-old woman presents with intermittent pain, numbness and tingling along the medial aspect of the right forearm and the hand, worsened when carrying heavy bags or raising her arm. She also reports of occasional hand weakness and feeling of coldness in the limb. On examination, there's wasting of the hypothenaminus, diminished sensation of the C8T1 dermatomes, and her radial pulse decreases when her arm is abducted and external rotated. So this is the question. This is the scenario that we have met. In this case, we like first what everybody should do is to break down this scenario so that you take the important facts out. Now, this is a 26-year-old woman who actually has pain and numbness and tingling in the medial aspect of the arm. So, primarily speaking, now this should have something to do with the nerves. In fact, it is the sensory innervation that is being somewhat involved, and so you should think about what are the nerves that are involved in providing sensation to the medial aspect of the forearm. Inadvertently, everybody knows that all the intrinsic muscles of the hand as well as the forearm, the medial aspect particularly, is provided by the ulnar nerve, which consists of nerve roots that comes from C8 and T1. So this is actually a nervous problem. Now, then the question further goes on with she says about occasional hand weakness, again that could be related to some sort of a nerve issue, and a feeling of coldness in the limb. So coldness particularly could be when there's compromisation of the blood supply to the hand. Now, what are the blood vessels that allow transmission of the perfusion? It is actually, when it comes to the hand, it is provided by a dual supply, which is the radial and the ulnar artery, but both of these are supplied by the inadvertently the brachial and the axillary arteries. So there should be some sort of a compromisation at at some stage of this arterial stream. So it could be a compromisation or the compression of an axillary artery, or it could be the brachial artery, or it could be radial or the ulnar. So again, now this leads to a sort of a vascular problem. Now, what you see in this uh, clinical scenario is that there is a nerve involved and there is a vessel involved. So further on, they also says about wasting of the hypothenaminus. Again, that is complementary with what we have already seen. Hypothena muscles are provided by the ulnar nerve, so this should have something to do with the ulnar nerve. Diminished sensation of C8 and T1 terminal, as we said, the medial aspect of the forearm is provided by C8 and T1 dermatomes. So, in fact, what you can come into as a conclusion would be the disruption of the nerves that supply the C8 and T1, which is actually the ulnar nerve. And the radial pulse decreases when an arm is abducted and external rotated. So there is the compression of the arterial tree. It could be in at any stage, but the what we can detect is the decrease of radial pulse. So as we take this as a whole, now this question actually implies a problem within the nerve and the vessels. So the nerves that supply the medial aspect of the forearm and the hypothenar muscles, and the vessels that supply blood to the distal part of the upper limb. You should look back and reflect at your anatomical knowledge and identify a space where you would see a possibility of a compromisation of both the vessel and the art vessel and a nerve simultaneously. Now, such a fine space could be identified in the axilla. If you can remember axillary space, uh, there is this space that is found in the region of the armpit, where there is this thoracic inlet and the thoracic outlet. So, a particular point where you would see a compromisation of both these structures would be the interscalene triangle. If you look closely at the interscalene triangle, now this picture demonstrates the interscalene triangle. It is a space that is found in between anterior scalene muscles and the posterior scalene muscles. It's a very fine space. However, this comprises of the brachial plexus and the subclavian artery. The subclavian artery is somewhat found very close to that of the rib. So the space is found between the anterior scalene muscle, the posterior scalene, and the rib, first rib. So for an example, let's assume that this patient is an athlete who has very profound and hypertrophied scalene muscles, or else it could be just anatomical variations, or sometimes even the formation of these ligaments. In all these circumstances, there could be the reduction of the space, which is already very spine space as well, reduction of the interscalene space, leading to the compression of these structures. Now, the two structures that are quite in jeopardy would be the distal part of the subclavian artery and the lower part of the brachial plexus. The lower part of the brachial plexus, in fact, consists of C8 and T1 nerve roots, which in turn will provide the nerve roots for the ulnar nerve. The ulnar nerve that in turn provides innervation to the hypothenar muscles as well as the provides sensation to the medial aspect of the forearm. Now, since the spacing is quite confined at the most distal part. Hence, the only the latter part of the brachial plexus are involved, not the upper part where there is ample space. And also, since the distal part of the subclavian artery is found very close to that of the rib, this is the point where it could get compressed as well. So, if the subclavian artery is somewhat compressed, there will be loss of perfusion to the upper limb, leading to consequences of reduced perfusion, which would the patient say would have complaints such as that of coldness, paresthesia, sometimes even and also a simple examination of the pulse detection would be unidentifiable. So in such circumstances, you think that this would be a compression at the interscalene space. But why not the vein? Now, if you can look at these interscalene muscles, the space, you would see that the subclavian vein is found anterior to that of the anterior to that of the the anterior scalene muscles, and will never be compressed if the compression is at the interscalene space. So the vein is spared. Now only the artery and the nerves are involved. So what you would see as the consequence would be in a patient saying uh, weakness of the intrinsic muscles of the hand, paresthesia of the lower part of the medial aspect of the forearm, as well as that of the lost radial pulse. So another quick point that you can remember would be that the phrenic nerve, which supplies the diaphragm, is actually found anterior to that of the anterior scalene muscles and will never be involved in thoracic outlet syndrome. So this is a single location where the muscles where the structures could be compressed. Now, as I said, this could be congenital or it could be in a patient who is of an athlete with hypertrophied scalene muscles. But another important phenomena would be the presence of a cervical rib. Now, if you can remember, cervical rib is actually an elongation of the transverse process. Now, uh, this picture shows you that there is this extra rib that is found as an elongation of the transverse process of the C7 vertebrae, which will in fact compress or reduce this interscalene space and thereby cause compromisation of both the nerves as well as that of the artery. So if by any means you think about the interscalene space compression, you think about the possibility of a cervical rib and make sure that you take an X-ray. In the X-ray, look at the possibilities of seeing a extra rib as it is shown here. So, simple test that you can do in order to identify the thoracic outlet syndrome where the compression is at the interscalene space or somewhere else could be by the detection of the pulse. The test is termed as Adson test, where you would ask the patient to abduct the arm slightly and extend it backwards, or extend it backwards, so that simultaneously patient, you should ask the patient to uh, look the chin should be tilted upwards, and look to the front, and also turn the head slightly in a rotating manner to the symptomatic side. So by doing the Edson test, what you also should be looking out for the radial pulse. But when you do these maneuvers, what would happen is that there will be compression at the scalene space, and thereby the radial pulse will disappear. A normal individual will not show this. Now, as I said, it is not only the interscalene space, which is the one which can cause thoracic outlet syndrome. There are two other spaces as well, but of lesser uh, prevalence when compared to that of the interscalene space, where the most common would be the presence of an cervical rib, but the costoclavicular space and the subpectoral space. Now, costoclavicular space, if you can look at this B picture, you would see that it is the space that is found in between that of the clavicle and the first rib. Now, this structure, this space, actually the comprises of the subclavian artery and the vein. The subclavian vein is of course found anterior to the artery, but both of these structures can get compressed. Now, in a costoclavicular space obstruction, you would see the particularly the subclavian vein will be the one that is involved. Now, what would happen is that the subclavian vein, because in this space, the subclavian one is found more or less anterior and found in a very close space, it can get compressed, and therefore the blood that is coming back to the heart from the upper limb will be somewhat retarded, and hence there will be venous stagnation. The venous stagnation will lead to swelling and sometimes even cyanosis. So if you identify a patient coming with swelling and cyanosis, you would possibly think about a possibility of a thoracic outlet syndrome, where the compression is of the vein at the costoclavicular space. It is not always cellulitis. That is something that you need to keep in mind. Right. The third would be the, the subpectoral space. The subpectoral space is found behind that of the pectoralis minor. Now, the third picture shows definitely in definition the space that you find behind that of the pectoralis muscle, compressing both the axillary artery and the vein, but profoundly the artery. So if there's a patient who is coming with no paresthesia, no ulnar nerve involvement, but you are thinking about the possibility of a loss of the radial pulse, then you have to think about axillary artery compression. The axillary artery compression can particularly happen at the subpectoral space behind that of the pectoralis minor muscle. A simple test that you can do would be to hyperabduct the arm as shown in this picture, where the artery, which is found more or less posteriorly, would be compressed against the rib and the scapula, leading to loss of pulse. So this is now, as a whole, thoracic outlet syndrome can happen in three locations, which includes the interscalene space, where it would show compression of both the nerves, the ulnar nerve, as well as that of the artery. But then there is this subpectoral space as well as the costoclavicular space. The costoclavicular space shows compression of the axillary vein, leading to venous stagnation. Then the pectoral space compression, subpectoral space compression leads to the compression of the axillary artery. So the patient would the main complaint that he or she will have would be the loss of pulse, the reduced perfusion, the coldness, the perishing cold, and sometimes even the pallor of the arm as well, which could be identifiable in a patient who is of fair skin, where there will be compromisation of the blood supply to the distal part of the arm. Right. So these are three locations, and but all signifying the particular syndrome, which is termed as thoracic outlet syndrome. Another thing that you should keep in mind is that in subpectoral space compression, now there is a particular point of axillary artery compression which will lead to stenosis over time. Once there's stenosis, there will be dilation at the distal part of the artery, which will lead to turbulence of blood flow, leading to thrombi formation and even uh, distal embolization as well. So post-stenotic dilation is another post-stenotic dilation, and the possibility of hearing a breathe is another clinical examination finding and a imaging finding that you would see in a patient with a subpectoral space thoracic outlet syndrome. Right. So we have illustrated the possibilities and the whole scenario that is associated with thoracic outlet syndrome, and we have uh, divided and categorized the particular topic as well. So we'll meet with we will meet with the next clinical scenario.